Check. Okay, guys, thank you. We're going to get started. I'd like to welcome everybody here to Inspire Carnegie Hill. I'm Brian Geiser. I'm the Chief Clinical Officer for Inspire Senior Living. And I want to start off by thanking our co-partners here, LifeWorks and the Alzheimer's Drug Discovery Foundation. They, together with Inspire, have created this evening program that we're going to enjoy together tonight. Inspire is dedicated to community education and integrative health and wellness based on 9 core elements, one of which is brain health. And today's program is going to approach brain health from 2 different perspectives. The first is the science. First, actually, we're gonna talk about Alzheimer's disease and how Alzheimer's disease affects the brain, with a specific focus on the latest in assessment, diagnosis, and treatment. And we're going to take a little bit of a deep dive into the controversial new drug that was recently approved by the FDA called Aduhelm. We will be introducing our guest speakers here shortly, but we have some amazing folks here to talk about Aduhelm, Alzheimer's disease, but also coming at it from a second perspective, which is the aging brain and brain health as we grow older. How do we optimize our brains as we age? And what's the science behind that? So we'll get into that. So we have a wonderful audience here of fully vaccinated, physically distanced folks right here at Inspire on our 17th floor Sky Park. So welcome to everybody who's here in person. And then we have a pretty large audience online, which we want to say hi to everybody on Facebook Live and YouTube. So we are going to kick off the program. I'm gonna pass it over to my partner Ball here in 1 second. And after our 2 presenters speak, then we're going to open up for a moderated Q&A, which will be questions both from the live audience here in the building and from the online audience as well. So thank you for coming again, and I'm going to turn it over to my buddy Ball. I'm going to pass the ball. It's a ball. There you go.
Yeah. Welcome. About 25 years ago, an executive from a tech company said, when the socks and laundry comes out of the dryer, the technology will advance to such a degree that you will say, socks, match yourself, and they will. So the same way as technology has advanced over the last 25 years, I fast forward to the next 25 years and saying, brain, fix yourself, and it will. And I believe in human potential. I believe in things that we have created and problems we have created and the problems we have solved. And I'm pretty sure with dedication of all the people involved, we will solve the brain health issue because it's such a focus. So my first gratitude to this evening goes to our brain, which works 99.9% of the time. And it does amazing things we have here. But once in a while, it doesn't work, and we have professionals to help us. My second gratitude is to Brian and to Inspire for becoming our partner. And finally, gratitude to Dr. Fillit and Dr. Berlin. Dr. Fillit has a vision. 25 years ago, he started Alzheimer's Drug Discovery Research Foundation. He's a founding member, and they have worked on thousands and thousands of research projects throughout the world. He'll give you more details of that. Dr. Fillit is also on faculty in multiple places, including Stony Brook, Rockefeller University. Let's see if I remember all of them. My brain. Rockefeller University, Stony Brook, Cornell Medical School, and Mount Sinai? Only Mount Sinai, okay, very good. And Dr. Fillit also has a private practice with a small group of patients. And with that, he's a good friend, great gentleman, Dr. Fillit. Welcome.
Do I need that? Oh, I have the. Well, thanks, Bal and Brian, for inviting me here tonight to talk to you about Alzheimer's disease. There'd be a lot to cover in 15, 20 minutes, so try to hit the highlights. Alzheimer's disease was discovered or described first by Dr. Alzheimer in Germany in 1906. And what he saw at that time was a 52-year-old woman who was demented. And so he knew that while senility was thought to be a normal part of aging, that a 52-year-old woman who was demented clearly had some sort of disease. And when she died, he did an autopsy on her, because that's what doctors did back then. They did their own autopsies. And he stained her brain with some dyes, and he found these plaques and tangles that characterize the disease today. And so Alzheimer's disease was originally described as dementia, as a pre-senile form of dementia associated with plaques and tangles. There was no research done on Alzheimer's disease basically until about 1970. And what happened in 1970 is that there were some pathologists working in London, and they decided to take the same dyes that Alzheimer used in 1906 and stain the brain of old people who were senile to see if they also had these plaques and tangles, and of course they did. So it was that day in relatively recent past that senility went from being thought of as a normal part of aging, oh, you're old, you get senile, fine, to being recognized as a disease of old age. Now, to put that in perspective, the Imperial Cancer Trust in London was started in 1902. So we're almost 100 years behind cancer. And look where cancer is today. So research really started around 1980. In 1984, a protein was discovered in the plaques called beta amyloid. And this became the first exciting finding in the field. In 1986, somebody found that the gene for beta amyloid was actually accounting for a genetic disorder in people who got the pre-senile form of dementia. So it linked the beta amyloid protein through mutations directly to the cause of Alzheimer's in young people. But there was still the vast majority, 95% or more, of people with Alzheimer's disease that are old, average age of onset about 75 or 80. But those were the first clues, the plaques, and then the tangles, which are the dying neurons that we can see at autopsy and Alzheimer's described. Now, I'll fast forward from then to today. Using those two clues over the last almost 40 years, that led to the recent approval by the FDA of the first disease-modifying drug for Alzheimer's disease, this aducanumab or Aduhelm that is developed by Biogen. So how did that happen? Well, first of all, we needed to be able to see the plaques in living people. So I run this foundation that funds Alzheimer's drug research throughout the world. And in the year 2000, 1999, I got a phone call from a doctor working at the University of Pennsylvania. And he said to me, I have a crazy idea and I can't get any money for it. And I said, what's that? He said, I want to take the same dye that Alzheimer used in 1906, and I want to put a radioactive fluorine on it. I want to make it radioactive, just a little bit radioactive. I want to be able to inject it into the artery of a patient. It'll go into the brain, it'll bind to the plaques, and it'll light up on a PET scan, which is something we do every day. Every city all around the world, we use radioactive dyes in microdose to detect disease. So we funded him for 4 years at Penn. In 2005, Penn spun out a biotech company called Avid Radiopharmaceuticals. They started developing this for approval by the FDA. In 2000, they were spun out with $7 million in venture capital. In 2010, That company was bought by Eli Lilly for $800 million 5 years later in milestone payments. And in 2012, that test became the first diagnostic test approved by the FDA for the diagnosis of Alzheimer's disease. The test is called Amyvid, and you can get it anywhere here in Manhattan. The only problem with the test is that today, because it's not approved by Medicare for payment, and we can go into why, it currently costs $8,000. Now, I use it in my practice. A lot of the patients I take care of can afford to pay that. It's amazing, because before there was this test, I could say to someone, I think you have Alzheimer's disease. I'm about 70, 80% sure. I'm an expert. With the test, they go to the radiology office, and within 24 hours, I can be 95% sure if they have Alzheimer's disease. That was a big breakthrough. That test is called a biomarker. Biomarkers are critical to drug development. The reason we funded the test was to accelerate the development of new drugs for Alzheimer's disease. And that's where we finally get to Biogen. Because it turned out that using that test, Lilly found out that almost a third of people that were being entered into their clinical trials to develop a drug to remove the plaques from the brain of people with Alzheimer's disease, about a third of the people that were entered into the trial had negative brain scans. And they didn't even have Alzheimer's disease. So how can you develop a drug? And by the way, clinical trials in Alzheimer's disease cost over $1 billion in the program. So you make a big mistake when you enter people into the trial that don't even have the disease. They don't even have the target of the drug you're trying to fix. So it was actually shown in clinical practice in a study by Medicare that doctors are wrong 50% of the time in making a diagnosis of Alzheimer's disease when the scan was done as a follow-up. So big impact on clinical practice, right? But the real value of the scan came with the recent announcement by Biogen. Because what Biogen did, one of the first times this ever happened, was that everybody who went into the trial had to have a positive scan to begin with. That was a breakthrough. That was a breakthrough in our field. I did one of the first clinical trials in Alzheimer's disease in 1980 down the block at Rockefeller University. I can tell you that the people, I have no idea who those people were that I put into that trial back 40 years ago. But Biogen knew exactly what those people had. That was the first time that we did modern clinical trials in our field. Imagine that. But think about the late start we got. Okay. Now, the other thing that they did was they asked the question, if we give this drug to patients with Alzheimer's disease, will it remove the plaques? So you take the initial scan, it's positive, the brain is filled with plaques, you give them the drug, and 18 months later, almost 90%, 85, 90% of the people that got the drugs, their brains were free of plaque. The drug worked. It removed the plaques from the brain. That's what it was supposed to do. That enabled the company to be able to ask a very important question in our field, which was, if you remove the plaques, do people get better? And getting better in this case means that they declined more slowly. Now, you've probably heard that there's a lot of controversy about this approval. And so the FDA had three choices, because I won't go into the technicalities unless you want to ask me, but it was a little bit of muddied waters about the data that came out of those trials. And it could be interpreted in different ways in terms of whether the drug really worked or not. But basically, the FDA had three choices. They could reject the drug and tell Biogen to go back and do another phase 3 clinical trial, which would have cost $500 million and taken 3 to 5 years. They could have approved the drug and let it go right on the market without any more studies. The drug has side effects, which we could talk about. Or they had a middle ground, which is a regulatory pathway that the FDA has for exactly the kind of situation we have here, which is a fatal disease, which Alzheimer's is uniformly fatal. You can ask me later how it kills people, but it's uniformly fatal. And there's a big unmet medical need. In other words, there's no other drugs, there's no drugs on the market for the disease. That's what we got. So the FDA has a middle ground, which is called accelerated approval. What that means is that if the drug hits a biomarker, in this case the brain scan, and there's a reasonable possibility, excuse me, I'm just going to make this lower. If you can, I don't know, all right. If there's a reasonable possibility that, that the biomarker correlates with, that can hear, yeah, we can hear that. If there's a reasonable possibility that the biomarker, or in this case it's called a surrogate marker, correlates with improvement in clinical status, okay, then the FDA will do what's called an accelerated approval. They'll let the drug on the market, but they require that the company do what's called a phase 4 trial to clear the muddied waters and demonstrate that the drug works in improving clinical situation. And if it doesn't, the FDA has the right to pull a drug from the market. Now, Biogen has 9 years to do that. A lot of times the studies aren't done. From what my conversations with Biogen and what I know, they're very committed to doing the phase 4 trial. So what the FDA did is totally within their regulatory rights. I think it was the right answer in a situation where there was a lot of uncertainty. But let me point out that that biomarker that our philanthropy funded in 2000 to 2004 at the University of Pennsylvania was the enabling technology that enabled Biogen to get the first drug approval on the market for, as a disease-modifying agent for Alzheimer's disease. Now, there are so many breakthroughs today that it's really exciting. We have a blood test for Alzheimer's disease on the market today, a blood test. That means somebody comes into my office and they have some memory problems, just like if you have high cholesterol or we take your blood pressure or whatever. There's a blood test for Alzheimer's disease, and it's a pretty good one, actually. And there's a lot of other ones that are in development. There's another brain scan that's probably going to be proved in about 2 years, maybe 1 to 2 years. Lilly's got it going, and it can detect the tangles. And the tangles actually are a better biomarker than the amyloid PET scan that is already on the market, because the tangles are the dying neurons. And so we can actually see the dying neurons with a PET scan in living people, and that correlates highly with cognition, with the loss of cognition with the disease. So that's going to be a better clinical biomarker, a better clinical test in practice, and it's going to be a better test to use in clinical trials. And then there's a blood test for the tangles that's going to be brought to market probably in a year or 2 or 3. That's being developed all over the world now, and that our foundation is supporting. That's going to be better than and will be used in conjunction with the blood test that's already on the market. Now, the last thing I'll say is that this is just the beginning. It's just the beginning. The reason it's the beginning, and it's taken 40 years, but that's the way science is, okay? That's the way it is, especially in developing drugs. 90% of people who work in the pharmaceutical industry spend their entire careers never working on a drug that comes to market. That's how hard it is. Failure is the norm. We've been at this 40 years. We've been at cancer and diabetes and hypertension for 80, 90, 100 years. So we're right on time in this historical framework, as far as I'm concerned. But what's happening now is that we're getting after other targets. Inflammation, which is characteristic of aging, also affects the brain. People that have inflammation around their plaques, that have inflammation in their brain with Alzheimer's disease, and we can measure that by brain scans, have a more rapid progression. Some of those people that have amyloid in their brain never develop cognitive impairment. About a third of people with amyloid in their brain in their 90s die with amyloid in their brain, with Alzheimer's disease, and they never develop symptomatic disease. It's like prostate cancer. 80% of men at age 80 have prostate cancer, but they don't die from it. Excuse me. So we're going after these other avenues, and right now there's over 120 drugs in development for Alzheimer's disease, and for the first time, about 60% of them are not against amyloid. They're not against tau, which was started from the pathology in 1906, but they're against all these other pathways that relate to aging of the brain, like inflammation, like what we call epigenetic changes in the DNA and the DNA mechanisms that occur with aging, like vascular changes in the brain that occur in most people with Alzheimer's and other forms of dementia, and so on. So it's a really exciting time, and we're currently at the foundation around the world, we're supporting with our funding over 35 drugs in clinical trials around the world, and only one of them is an anti-amyloid drug. And what we're trying to do, I'll close with this, is the current drug on the market, which is the Biogen drug, it's estimated to cost $56,000 a year. That's just the cost of the drug. The total cost of administering the drug in a year is about $100,000, okay? If you multiply that by 1 or 2 million people that might be eligible in the United States to get this drug, and quite frankly, there's many, many more millions who are eligible, but they're going to have strict guidelines for this drug so that not everybody goes after. You're already talking about 50, 60, 70 billion dollars, and the entire Medicare drug budget is only about $450 billion. So you're talking about a drug that could eat up an enormous part of the Medicare drug benefit. So we're going to have tight framework around this drug. But it's an IV infusion, once a month. You got to sit there. Its benefit is on the border of being clinically meaningful. There's side effects in 40% of people. What we need is a pill. We need a pill that does the same thing, like Lipitor. We need a pill, and that's what we're funding. We want to get beyond the IV infusion that costs $56,000 a year to a pill that's much less expensive and much less burdensome. And we'll get there. We're going to get there. So let me close by saying it's incredible. I've been doing this 40 years. You'd say, you know, Dr. Fillit, you've been at this 40 years. You don't have a real success. But, you know, as I've seen the science emerge, it's just I've seen us go from a time when we knew nothing. I'm serious. We knew nothing about Alzheimer's disease to a time where it's very exciting. And I can see the future where we're going to have drugs on the market and blood tests and brain scans, and it's going to be a disease that we'll manage the same way. If you remember, HIV came about and we had no idea what we do, and cancer, people were dying. I mean, they're still dying, but we consider cancer a manageable disease today based on the biomarkers and so on. And that's where we're going with Alzheimer's. Just like cancer, people are on 4 or 5 drugs based on their biomarkers. If you get the cancer, you get cell typing, you get the serology, what's called the serology. We find out what your biomarkers are, and then we give you the right drugs for that. And I'd say 5 or 10 years from now, most people with Alzheimer's disease are going to be on 4 or 5 drugs attacking these different pathways. So thanks for your attention, and I look forward to answering any questions you have.
Thank you, Dr. Can you hear me? Thank you, Dr. Fillit, for sharing the challenges and giving us the hope for the future. Dr. Fillit will be available for Q&A later. Those who are in live stream, you can send your question through the feed, and those who are here will get a chance to ask the questions live. I have also the pleasure of welcoming Dr. Heather Berlin. Dr. Berlin is a cognitive neuroscientist. She's clinical psychologist and associate clinical professor of psychiatry and neuroscience at Icahn School of Medicine at Mount Sinai. Did I say that all right? She specializes in lifespan treatment of anxiety, impulsive, and compulsive disorders, blending her natural perspective with cognitive behavior therapy, mindfulness, and humanistic approaches. It's a completely different way of looking at life. If Dr. Fillit cannot fix my brain, then Dr. Berlin will. Thank you. Welcome, Dr. Berlin.
Thank you so much. Thank you. Oh, yeah. Do you want to speak? Oh, I don't need a mic. Oh, yeah. All right. this mic down over here. Let me just get this set up. And OK. So are we good? You're good. Thanks for having me. I'm really especially excited because this is my first live event since March 2020. So thank you for welcoming me back into the world. Thank you. Very excited to be here. So I'm going to talk just a little bit about the brain, the aging brain, and some sort of practical tips about how to keep our brain healthy as we age. So let's see if this is working. Aha, there we go. So there's the brain, this 3-pound piece of matter, and I think it's the most fascinating thing in the known universe because it's the only thing, as far as we know, that can know itself, right? And it's your most valuable asset. It's the source of all of your creativity, all of your emotions, your feelings, your thoughts, everything. And so I became fascinated with the brain at a very early age. I was 5 years old, and I realized for the first time I was going to die. And I was very freaked out by that. And I thought, well, even if I die, can I still keep my thoughts? Can I still keep my consciousness? So I asked my dad, where do my thoughts come from? And he said, they come from your brain. And I said, OK, great. How? Because I want to keep them when I die. And he said, we don't know. And I said, well, what can I be when I grow up to figure that out? And he said, I guess a psychiatrist. But that began my journey to try to understand how this physical piece of matter correlates to all of our subjective states, to who we are. And it's a very complex piece of matter. It's made up of these individual units, neurons. We have about 86 to 100 billion neurons in the human brain. They each have about 1,000 to 10,000 connections or synapses. So there are about 100 trillion connections in the human brain, which is more connections than there are stars in the Milky Way. So very complex piece of matter to try to understand and deconstruct. And you can kind of think of it like an information processing machine. It encodes, again, all your thoughts, feelings, emotions. But it's a myth we only use 10% of our brain. We use all of our brain all the time. It never really stops. But it's just very little bit of it is conscious. Most of what's happening in your brain is happening outside of awareness. It's happening unconsciously. It's motivating your behaviors. We often think we are the masters of our own decisions, but we can use some neuroimaging techniques to see that we can predict up to 10 seconds whether you're going to go left or right before you're even consciously aware of whether you're going to go left or right. So very complex piece of matter, but we feel like we are the master of our own intentions. And so in the lab, we can test people. We can look at subliminal stimuli like this to see what is the neural basis of these unconscious processes that are motivating our behaviors and our thoughts. So can you see the subliminal message here? Anybody? Raise your hand if you can. So see in the negative space by the roots, it says SEX, right? And then you have the birds and the bees. And the flowers are kind of loving towards each other, right? So now once you see that, you can't unsee it. Something changed in your brain, right? And if I show you this in an hour, it'll pop right out at you. And so that's what we want to track, because the stimuli reaching your visual cortex being processed remains the same. The physical stimuli remain the same, but what changed was your perception. And that's what we want to track. What's different in your brain when you see it versus when you didn't? And what we know is that these coalitions of neurons start firing together, and they firing sort of in sync, in coordination. And that's what brings a percept up into consciousness. And they can last a few seconds. If you attend to something, it lasts longer until the next coalition of neurons comes into power. And that's the ebb and flow of your conscious perception. And I liken it to a Twitter feed. So like if each neuron firing is like a tweet, if enough people tweet about something, it starts to trend. And that's kind of what it's like in our brain. When things start to trend in the brain, that's when we become consciously aware of it. And it's not that the neurons are firing exactly the same time. They're firing in coordination and sync. So if each person is a neuron, they're not all standing up and sitting down at the same time. That would be like an epileptic seizure. But in sync, in coordination. And across, this is the white matter tracks in the brain. So these neurons are communicating by the rate at which they're firing, but they're also connected via these sort of pathways in the brain. And when we start to look at the aging brain, it's not only the gray matter that's aging, but there's changes in these white matter tracks as well that send information in this sort of information processing machine that also can get degraded over time. And so if you can see this, I don't have a pointer, but so at the top on the left is the healthy brain, and next to it is an aging brain. And we all have some level of changes as the brain ages, just like the rest of our body ages as time goes by. But the difference is when you look at the regular an aging brain versus an Alzheimer's brain, you can see it's an accelerated effect of degradation of not only the gray matter, but the white matter tracks as well. So the ability to send information and communicate to different parts of the brain is also affected. And like was mentioned, it's a subtle, there's a difference between when people talk about dementia, which is sort of an umbrella term, and Alzheimer's, which is a particular type of dementia, which Dr. Fillit was talking about, the plaques and tangles that occur. And that's a particular disease process. But dementia is sort of any kind of cognitive degradation that we start to have. And a lot of people come to me and say, I'm having these memory problems. Is it Alzheimer's? Is it not? And you can see there are signs of normal aging, forgetting things, forgetting words, not remembering why you walked into a room. But with Alzheimer's or other neurodegenerative diseases, it's much more accelerated, it's much more dramatic, and so it's really a difference of degree over time. But having these biomarkers, I think, is really important going forward in the future to really be able to, right now, often people do neurocognitive testing, non-invasive, but if we could have a blood test that can tell us early on, and then the next question is well, what are the interventions? If you find out that you are in the early stages of Alzheimer's or another neurodegenerative disorder, what can you do about it? So if you kind of look at this, is the green line is a normal aging. You can have mild cognitive impairment, and then again with dementia, it's this accelerated aging. And so the question is, what can you do to get back up from normal aging to get to a place where you can increase your brain health? And I'm going to quickly just go through a couple of very practical things that you can do, all of which are going to be pretty intuitive, so I'm not going to spend a lot of time on them, but they're all interrelated. We talk about inflammation, how to decrease inflammation in the body. So eating healthy, physical activity, good sleep habits, stress management, social connections, and cognitive exercises. So very briefly, foods. And I'm imagining that many of you are very familiar with this, but I'm just going to point them out. Having really good healthy fats, so that white matter that coats the axons of the neurons and sends information, it's covered with a fat. And so you want to feed that fat with healthy fats. Leafy greens, berries, we're finding, which can also translate into wine. Caffeine can help with cognitive enhancement, and nuts are very healthy as well. So these are some examples of foods, and stay hydrated, of course. But I think really also important is sleep. So we're learning a lot about sleep, and we can understand what sleep does by seeing what happens when people lack sleep. And we see when people have had a shortage of sleep, they have memory problems, they have problems with attention, they have problems even appreciating humor. The good news is that you can recover these things with sleep, and naps seem to really help. So taking a nap can really give you a boost in terms of your cognition throughout the day. And I'm not going to get into the very technicality of it, but there's theories behind what sleep does. And one of the things is that when you're learning throughout the day, your neurons are kind of changing. They're picking up information, and their learning is actually strengthening the connections between neurons. But that takes a lot of energy. And what sleep does is this kind of reconsolidation process. It can transfer short-term memories into long-term memory storage, and then it decreases the amount of energy the brain needs to use. So for all these reasons, again, sleep is really important. And finally, we've found that sleep can clear out the toxins from the brain. So a lot of these proteins and the beta amyloid that can build up in the brain, this debris, can get cleared out with sleep as well. And again, refresh the brain and keep it younger and healthier. And so in terms of amount of sleep, it really does vary, and there are individual differences. But for older people, we need less sleep because the young brain is learning a lot, it's absorbing, it's changing, it's this process of neuroplasticity. As you get older, you're still changing and learning. It's just the process slowing down a bit, so we need a little bit less sleep than we did when we were kids. And these are just, again, very simple sleep habits. Stick to a schedule, practice a bedtime routine, keep the bedroom cool around 65 degrees. If you can't sleep or go to bed, get up and do something else, and then come back to bed. Reserve the bed for sleeping and intimacy, but not like don't eat in bed and do a lot of other activities in bed. You want your brain to associate it with sleep. Watch what you eat. Don't have caffeine late at night. Don't eat heavy meals late at night. Stay away from also alcohol late at night. It seems like it puts you to sleep, but actually then when it breaks down into sugars, it can wake you up, and so you have a shorter and less sort of active sleep, less productive sleep. Get regular exercise, avoid sleeping pills for too long, and light can keep you awake, right? So darkness stimulates the melatonin in the brain that puts you to sleep, so try not to be looking at your phone late at night and disconnect. Okay. Exercise, I think, again, we all know why exercise is important. It's really important for the brain. So a lot of times when people come to me and say, what can I do to keep my brain healthy, I say exercise. You're increasing blood flow to the brain. You're decreasing the inflammation, which we talked about is not good for the brain. And then you can sort of combine it with stress management if you do things like yoga, where you're both getting the value of exercise and decreasing stress as well and the inflammation. So meditation, again, doing even journaling can help lower your stress levels, all really important. And socialization. So whether you can't be in touch with people in person, even a Zoom call, studies show that just socializing with one person, interacting with one person a day can stimulate your brain in these very positive ways. Social interactions require a lot of, they're very cognitively demanding. And so that's another area that you can work on. And then finally, these cognitive tasks. And the thing that I would emphasize most is change. So the brain likes change. It releases dopamine. And so if you're doing, let's say, crossword puzzles every day, switch it up, do Sudoku, or these online games can be really helpful, but do one for a week and then switch to something else. Keep changing it up. It's like a muscle, but you want to not always exercise your bicep, then you want to use your tricep as well. And finally, there's just this interesting study where we looked at curiosity in the brain. And so when ask people a question, and then you ask them to rate how curious they are to know the answer. Then they asked the question and showed them random faces in between before they gave the answer. And what they found was that their memory was better for the other information, like the faces, which were irrelevant, once their curiosity was piqued about something else. So curiosity is like a vortex. Once you become curious about something, it kind of sucks in the information around it. So the point here is to stay curious. And it also activated these pleasure centers of the brain. So curiosity was almost like a drug that released dopamine and gave people a little bit of a high. So finally, yes, as we age, there are changes in our brain, but there are different types of intelligence. And I'd like to point this out. There's something called fluid intelligence, which is kind of peaks in middle age, and it's logic and reason and problem solving. But then there's something called crystallized intelligence, which continues to increase as you age. And that's, I think, what we consider wisdom. It's knowledge of facts. So as you can see, as we age, things like working memory, processing speed, we slow down. But this crystallized intelligence, this knowledge of the world, this wisdom, it keeps increasing. So as we know from psychiatric illnesses, people who come to therapy, the brain can change at any age. We know that people can get better, whether it's a psychiatric or neurological condition. Throughout your life, yes, it's like a piece of clay. So when you're young, it's much more malleable. We're born with many more connections than we need. And as we age and as we interact with the world, it's like a pruning process. So we get rid of the connections we don't need, and we keep the ones that are salient. But even though the clay kind of hardens throughout our life, it's never fully solidified. So there's always room for change and improvement. So I think the more that I learn about the brain, the the more I realize just how little we understand still about the brain. It's so complex. We still don't really have an overarching theory of the neural basis of consciousness. That question I was asking when I was 5 years old, we still don't really fully understand the answer. And we don't know whether these AI systems are going to have it. Are they going to have conscious awareness? Does a fetus have it? Does a bee have it? Does the internet have it? Until we have an overarching theory of the neural basis of consciousness, we might never know. But what we can do with the knowledge we have so far is try to look inward, kind of this saying, know thyself. That's what people do in therapy, to try to understand these unconscious influences and live more in line with our long-term goals, and ultimately achieve wisdom, which I think is having experience, knowledge, and good judgment. So I started out studying the brain and consciousness to figure out how my thoughts can survive death, and I didn't find that answer, but I'm left with a feeling of awe that this piece of matter can ask these questions and attempt to answer them. So I'll leave you with this. I think the brain is both delicate and robust. It's easily damaged, but impressively able to heal itself. And no matter where we are in life, at any stage, it's an ongoing process of self-creation and self-discovery. As we're being shaped by our experiences, we're guided by our genetic code, and we're a work in progress until our very last breath. So thank you, and I'll leave it there.
Come on up. Okay, so we're going to open it up for Q&A. Bal and I will moderate that. And we have questions coming in from YouTube and Facebook, which we'll take, and then questions from the audience. I have a couple questions I wanted to start out with. First, Dr. Fillit, if you had early Alzheimer's disease today, would you take the new Biogen drug?
Actually, we just had the National Academy of Sciences just had a 2-day meeting about this question. And I think we need to refine the question a little bit that you asked. People confuse the term as, I forget your first name. Heather. As Heather said, dementia describes the person's clinical state and Alzheimer's is the cause, but in 70% of the cases. But the question you asked if I had early Alzheimer's disease is, we have to ask the question, do you mean early symptoms or do you mean early disease? Because we know from the brain scan that the Alzheimer's disease starts in middle age. Like we can detect people in their 40s and 50s that have Alzheimer's disease in their brain, but they're asymptomatic. And they don't become symptomatic till they're like 70, 75, 80. And some people never become symptomatic. So if you're asking me if I had symptoms, the early stages of symptoms, would I take the drug? I don't know the answer. I think I would want to look at my other risk factors. So for example, there's a very powerful genetic risk factor called apolipoprotein E. And this gene, the protein product of this gene carries cholesterol in the blood, and it does about 100 different things. Now there's 3 types of ApoE, ApoE2, ApoE3, and ApoE4. About 70% of people have ApoE3, one from mom and one from dad. And about 20% of people have ApoE4, and about 5 or 10% of people have ApoE2. People that have ApoE4, even though they're 20% of the population, they represent 60% of the cases of clinical symptoms of Alzheimer's disease. And they get their symptoms about 10 years earlier than everybody else. So I would want to know my risk. And also, people that have ApoE4, they have more side effects from the drug. So if I was ApoE4, I might think, well, I'm going to progress a little more rapidly, but at the same time, I might have more risks from the drug. So I'd have a different risk-benefit. If I had no symptoms, and you were talking about early Alzheimer's before there were symptoms, let's say I had the blood test, because I was a little concerned at age 55 or 60 that maybe I have changes, so I go for the blood test is positive. Now I'm ApoE4, now I know I'm at much greater risk. And so there's supposedly there's 6 million people with symptomatic Alzheimer's disease. The recent estimates are there's about 47 million people with positive brain scans. and positive Alzheimer's. So that's the way the thinking is going to go forward. Now, the other thing I might do is I might go to Heather. And I might go to Heather if she's doing neurocognitive testing, because I'd want a better profile of exactly what's going on with my brain. And
So you're saying that these scans that have come out that can diagnose Alzheimer's disease are not going to put Heather out of business?
no, I think
You need both.
well, what might
You need both, is what you're saying.
What might so you have screening cognitive tests that take 10, 15 minutes, and then you have what Heather does, which I don't know, probably takes 3, 4, 5, 6 hours. But now we have digital biomarkers, which are really amazing. You know, like you can do it on. There are products out there where you can do cognitive testing on your phone. You can do all kinds of things with digital tests, and I think that's going to help with the screening process to get things done early. And ultimately, some patients need to be referred or want to be referred to make sure, you know, where they are in their cognition to see if I was really, really early, I'd have a different equation than if Heather told me, no, you've really got it.
So it sounds like the answer is complicated, and I think the one thing I want to stress here is that just because we have a new Alzheimer's drug FDA approved on the market doesn't mean that it's for everyone, and it doesn't mean that we should rush to the doctor to go get it. It's an extremely complicated clinical scenario, as you could tell, but also there's massive cost involved. There's potential significant side effects. It's an IV infusion every month. We don't know if it's actually going to work. We know that in one study it cleared amyloid, in another study it really didn't. So it's much more complex than just saying, "Yay, let's go get this new drug." Okay. I want to turn. We do have questions coming in from the audience. If you could please keep your questions brief. We're going to have a lot of folks, and I want to make sure we can get to everyone. Yes, sir.
Yeah.
Is there an economic test for ApoE? That sounds like a very. Is there an economic test for which ApoE you might have?
What do you mean by
Economical and like cheap?
Just a
Right.
blood test.
Oh, cheap.
Is there
Yeah.
a cheap test you
It's
could
a
do?
blood test.
Yep.
And you send your blood off to a specialty lab, and I think it's about $800. And that test is paid for by insurers.
If you're at risk?
Yeah, well, it's also a risk for cardiac disease, so Quest does it, and so it's paid for by
Thank you.
insurance.
There's more questions.
Okay.
Let me just take- Also, those who are in the live feed, they can send their questions through the live.
The blood test that you mentioned, if somebody could just come into your office, you'd be able to do a blood test and test them. Is that test available with all neurologists?
So let me say, the test is approved by Medicare for clinical use in 49 states at this time. And the only one that's not approved is in New York. New York has a stricter regulatory problem.
The irony.
Stricter regulatory problem, but it will be. And then what happens is your doctor has to get these special tubes and fill out a form. But then the blood, basically, it'll go to Quest or someone like that, and then it'll be sent to a specialty lab in California. So the answer is yes, any neurologist will be able to order the test, except in New York State.
Do they know about it, though? Do most
It just came on the market about a month ago. They're still rolling it out. So I give them 6 months or so, and it'll be available. 3 to 6 months.
At what point is it useless to try and do anything about Alzheimer's? And conversely, at what age or stage is it most effective, treatment is most effective, when it's diagnosed at a certain age or stage?
Well, in terms of doing nothing, I had a patient today that's with moderate severe dementia. They can't shower, they can't use a knife and fork, they have no words, they don't know where they are, they barely recognize their son, they have no quality of life. And so we talked about palliative care for that patient, end of life care, but not quite end of life, palliative care, like if they got pneumonia, would you give them antibiotics, for example? So if you mean that, then probably at the moderate to severe stages, we start to try to make the goal of care quality of life, comfort, and safety. But on the other hand, the earliest things that can be done today are prevention, which is what Heather's talked about. And we know from very large studies that prevention is possible. There's a colleague of mine out of Helsinki named Mia Kivipelto, who ran the first randomized clinical trial of prevention, where she took all the things that Heather was talking about and used a very intensive intervention to treat one group of people, and then kind of not an intensive intervention. She kind of gave Heather's lecture to these people in a clinical setting, but then they were off on their own, whether they adhered to it or not. And she found that the people that got the intensive intervention, their cognitive decline was actually much less. And this involved all kinds of things, including all the things that Heather was talking about, plus things like hearing loss and a whole variety of things. Don't smoke. If you're obese, lose weight. Relieve stress. Treat your diabetes and hypertension very aggressively. So there's a lot you can do in terms of prevention. And ultimately, because we know from the brain scan that the disease starts in your 40s and 50s before there's symptoms, there's actually a clinical trial going on sponsored by Biogen and another one sponsored by Lilly, where they're treating people that don't have any symptoms. It's like giving a statin to somebody with a high cholesterol who's never had a heart attack, and treating people without any cognitive symptoms to see if you get rid of the plaques before there's symptoms, if you can prevent people from ever getting symptoms. And that's the kind of prevention treatments on the horizon where we're going to combine all the things that Heather talked about with drugs, the same way that to prevent a heart attack, we advocate and educate people to do lifestyle, treat your diabetes and hypertension, but also take a statin.
I think, no,
Sorry.
I was going to say, so one thing to keep in mind also is that Alzheimer's is just one of the dementias. There's also like frontal temporal dementia. There are other different types that we don't necessarily have biomarkers for. And so these preventative measures, the lifestyle things that I've been talking about, in lieu of having a cure or being able to reverse it, at least right now, I think it makes sense to do those things anyway as preventative. And if it slows down this deterioration enough that people can age out, in a sense, like you end up dying of something else because you staved off that brain degradation, that is sort of the kinds of things we're thinking of. And because the disease process does start as early as in the 40s, start living that healthy lifestyle now. And there's something also called cognitive reserve. People who have used their brain a lot in different ways, even if they start to deteriorate in some ways, will have enough reserve left over that they won't have as much of that impact. So like he was saying, you can see the same plaques and tangles in two brains, but that's not enough. So you do an amyvid PET scan, you see that. It still doesn't necessarily correlate to having the actual cognitive deficits of what we care about as we live our lives. And so even if the disease process is ongoing, if you do some of these lifestyle changes, you might be able to not see the negative effects of the disease and other dementias as well, not just Alzheimer's.
And I agree with Heather completely. One thing she didn't mention is vascular dementia, which is actually the second most common cause of dementia in older people, and maybe the most common cause in people over 85. And of course, vascular disease is prevalent throughout our population. And actually, while it accounts for maybe 20% when it's pure, about 50% of people living in the community have a combination of Alzheimer's disease plus vascular dementia. So managing these vascular risk factors to prevent a heart attack, which you all want to do anyway, is also going to have a big impact on preventing dementia, as Heather was saying.
I have a question coming in from YouTube. Can you turn my volume up a little bit, guys? So this is a good question. If you're already in a clinical trial of Aduhelm, where you have a 50-50 chance of going on placebo or not, should you just back out right now?
Yeah, I mean, people that participate in clinical trials are a special group. In cancer, in heart disease, and in Alzheimer's disease, less than 5% of people with those diseases actually participate in clinical trials. And it's partly because they're burdensome. It's a lot of big commitment. And in Alzheimer's, it's even more because you have neuropsych testing, which takes a long time. You have brain imaging. and so on. And yes, you could go and get the drug. It's a very personal decision. The characteristics of people that stay in the trial, they tend to be more altruistic, and they tend to want to contribute to society. But we are worried about the advent of the drug in terms of how it's going to impact the ability to recruit into clinical trials if people say, well, I could just go get the drug versus being in the trial. But if only less than 5% of people, and those are a special group, actually go into the trial, I actually don't think it's going to be a big impact. I think we'll be able to run the trials going forward anyway. And most people, by the time they get into a trial and they've gotten a lot of basically free services, and they're well evaluated and they like being in the trial, the dropout rate is pretty high in these trials, but most people run through the trials and complete them.
Okay, we have any question here in the front?
Yes.
Thank you. Got to give you the microphone here.
Thank you. Thanks, Bob. It's probably a somewhat naive question, but if you're in a clinical trial, and say Biogen has got the trial going, and we have Eli Lilly developing something else, and your trial is going to take, some years to see it to fruition. To what extent are you bound to just proceed along with your original model, or are you professionally bound to take into account what progress has been made in different areas that should be incorporated, either by Biogen or by some other company, or does somebody else come from the background and do their own thing, incorporating the two things, if they can, from your study and Eli Lilly?
Yeah, we're with 120 drugs in development. Sure. The question is real. I think the question is how bound is a patient or what we call a subject to a particular clinical trial when they've entered it to stay in it, or they can jump around or choose another drug. And the fact is that when you sign up for a trial, you're still free to quit anytime you want. And you can jump around. I mean, it may be that if you go into the Biogen trial and you're in it for 6 months, and then you want to jump to the Lilly trial, they'll say, well, you still got the effect of that drug, and it's what we call an exclusion criteria. So you might be excluded for 6 months or a year from going into the other trial. But basically, people are free. You're not signing a contract that says you have to stay in anything. You're only signing a contract that says you understand the risks and the procedures.
But the clinical trial stays as it was.
Yes.
Okay, so we're closing in on time. We're gonna do about 5 more minutes. I wanted to pose a quick question to Heather. We have this lovely lady here drinking a glass of red wine.
Yeah.
Should we all drink red wine, Heather?
There's this, so it's within the red grape, there's something, there's a chemical that's in, you can just eat berries without getting grapes, yeah. You don't, so too much, there's negative effects to alcohol too, right? So you want to try to get the positive effects of the chemical that's in the grapes, but too much alcohol won't be good either. So I would say in moderation, yes, it can be helpful. But there's one thing I wanted to mention about the blood test and about the APOE4, because, and my husband's comfortable with me saying this, he's he has both copies of the APOE4.
Your husband does.
My husband does, which puts him at high risk. And he's in his early 40s now. But there is a question of, and I think everybody needs to think about this, is that something you want to know?
Because what happens, what do you do with the information?
Right, and there's, I mean, he's sort of, just like live hard and, die young kind of mentality. I don't know that I would want to know, because it bothers me so much even just knowing about him, and that it's almost like it feels like a ticking time bomb, even though it's not 100%, he has a significantly increased risk. And so I think everybody needs to ask that question. If there is no cure per se, is that some knowledge you do want to know and live with that, or just engage in the healthy lifestyle regardless and see what happens.
So that's interesting because statistically speaking, in this room, regardless of your age, how many people have Alzheimer's disease in their brain right now?
And depending on their age.
Depending on their age, but
Well, I think it's a good question. I think in the 70s, let's say,
yeah.
about a third of people have
So 1/3 of people in their age 70 or old.
75, say.
So if you're in your 50s, what's your likelihood that you already have Alzheimer's developing, knowing that you may never develop symptoms?
If you're in your 50s.
Yeah.
What's
I mean, I don't know anyone in their 50s. I'm just asking.
yeah. Well, if you live to be 75,
Yeah.
then you have a 1 in 3 chance of getting it.
Okay.
There's one more question.
Well, we're going to take 3 more questions. We got 1, 2, 3. Okay, go.
You actually just answered my question, I think, which is if you think you're genetically disposed, the healthy lifestyle is, a lot of that is common sense, and we should all probably, strive for what you recommended. But my question is, what else should you be doing? And it sounds like the medical is really lagging the sort of lifestyle and what you can do. You could be proactive today, but it sounds like there's really, if you're asymptomatic, you think you're genetically disposed, it sounds like medically there's not really much you can or should be doing today. I guess that's
Well,
my question.
I'd like to just let Heather speak, but I think one thing is family history. So let's say you have a brother that might be at risk, or let's say both your parents had it, but they got it at age 80, and you had a cousin that had it. So if you have a strong family history, then you might want to know what the cause of that is. And if it's ApoE4, then that's, especially if you're like Heather's husband, 2 ApoE4s, Heather knows one of her kids is going to, her kids are going to have ApoE4. So selfishly, her husband's going to lead a healthy lifestyle. But unselfishly, he might want to get involved in research on ApoE4. He might want to advance the field. He might want to go into a clinical trial where all the clinical trials are looking at ApoE4, the way people with ApoE4 react to it. We're funding gene therapy at Weill Cornell down the block. So remember I said there's 2 kinds of ApoE2, ApoE3, ApoE4. ApoE3 is normal risk. ApoE4 is bad risk. ApoE2, you're protected. So what we're doing is, and what I should say what the doctor at Cornell is doing, is he's made a virus, a non-infectious virus, that has the DNA for ApoE2, okay? And he puts the DNA for ApoE2 in the virus, and then he's injected it into monkeys and into people now. We're in human testing to see if we can make the ApoE4 brain, people that are double 4, like Heather's husband, to make ApoE2 with the idea that the ApoE2, and we don't know how this works, and we've tried many, many different ways to fix ApoE4 with no success. But this should work because it's a genetic disorder, and now we're treating it with genetic therapy. So we're looking, the doctor at Cornell is looking for people that are double 4 to enter into this trial to see that if he adds the ApoE2 gene, it'll offset the risk. And that'll be a major advance for people that have double 4 or even single 4. So I think that, if you're double 4 and you have a family history, that there's lots you can do that's more than just for yourself.
Okay, so you're going to be pressuring your husband
Yeah, I'm
tonight.
ready. Let's get
The
him in the
conversation
trial.
to talk
We
to
can
Dr.
talk
Fillit. Okay. 2 more questions. Yes.
I know we are concentrating today on about Alzheimer, but I wanted to ask you about, this is a little close to me, about anxiety. How can these thoughts develop anxiety even if it's not reasonable?
This is a Heather question.
Yeah, this is a Heather question.
Yeah. Anxiety involves lots of different parts of the brain, but if you think of anxiety as everything that we have is adaptive, but when it becomes too extreme, it becomes maladaptive. So it's really, we have this it's fear of something bad happening in the future. Nothing is happening in the current moment, but it's like, oh, something bad might happen, so I better prepare in advance for that, which is adaptive. But there's a circuit in the brain that's thinking about that when it's overactive, and it's parts of your prefrontal cortex that are, particularly your orbital prefrontal cortex that's overactive, then you have, it's an abnormal fear of future threat, if something bad might happen. And so we can identify the neural circuit involved with anxiety. There are different techniques that can decrease that. You want to decrease activation in the prefrontal cortex. Meditation is one of them, getting into flow states, getting absorbed into something like creativity, exercise when you're exercising. And when you decrease those parts of the prefrontal cortex, you lose your sense of self. The rumination decreases. So the more we can map out things like anxiety in the brain, and when we understand the neural circuit, we can help people decrease activation in that circuit and decrease the anxiety. So, but there are genetic components, but it's really, it's kind of the way your brain is wired up that overvalues potentially bad things happening in the future. Say that again?
Parkinson's medication?
Can that happen from Parkinson's medication? What we've seen, I haven't necessarily seen an increase, but we do something called deep brain stimulation for Parkinson's. We implant electrodes when the dopaminergic medications don't work, and we have seen an increase in impulsive behavior. So it's actually the opposite of anxiety. If you think of anxiety as not wanting to do anything, being really risk averse, they become actually more impulsive and start doing risky behavior. That's something we've seen. Yeah.
We have time for one more question. Did you have a question?
I just wanted to know that besides the genetic component, you mentioned that it's like prostate cancer. Some people have the disease, but they don't manifest it, and some people do manifest it. What triggers people to have it and others to go lifelong and not have it, like prostate?
Well, Heather mentioned resilience. So there's a lot of research on now starting up about why people are protected. And we want to understand why people can be 100 years old and maybe even have amyloid in their brain and they never develop symptoms. And part of it, we think, is inflammation and how their inflammatory response to the plaques.
That's lifestyle.
But it also could be how you build your brain. So there have been studies all around the world showing that the number of years of education that a person has correlates with their risk for Alzheimer's. In other words, the more years of education you have, how you build your brain in early life, and how you maintain your brain throughout life in terms of cognitive stimulation, reduces your risk for Alzheimer's, for clinical Alzheimer's, and is a form of resilience.
It's a lifelong journey.
A lifelong journey. I don't know if you want to add anything
Yeah,
to that.
exactly. You build up, that's what I was talking about, this cognitive reserve, but the more you can build up kind of your reinforcements, so you can afford to lose some bits and still have enough to keep you functional in a way, so it is a lifelong process, yeah. Yeah.
I want to
Yeah.
just point out that all of the food that was made here tonight by our chefs are brain power foods, all vegetable-based, and things like blueberries and nuts and so on and so on. So our chef did that on purpose tonight. So I want to thank him. Thank Dr. Fillit and Dr. Berlin for their expertise. Thank you all for coming tonight. And we'll see you next time.
Thank you. Nice. Yeah, good to see you.